Good morning, friends. Our next topic is on assessment of fetal rhythm and its aberrations. The assessment of fetal rhythm is a little challenging because, one, we do not have an ECG possible. The next slide is not moving. We do not have an ECG recording possible. Second thing is, sometimes we might have the changes which are intermittent. Third thing is, we have to treat the mother to get an effect on the baby. And the last is, there are certain parts of the ECG which we can never document. For example, QTC. So repolarization abnormalities cannot be diagnosed. The most common is actually a benign change in the fetal rhythm. It's important to understand that the heart rate of the fetus will decrease with increasing gestation, and there are few clear definitions where we would define bradycardia as less than 100 per minute for 10 minutes, and tachy for more than 180. However, if you have persistent rates between 100 and 110 and between 160 to 180, that is also not considered abnormal if it does not have variability. And hence, the most important thing is sometimes you will end up with multiple assessments. So what in this short time we will understand is the basics, a little understanding about the irregular rhythm, tachy and brady. Now the conduction system fully develops by 16 weeks of gestation, and there are 3 phases in the cardiac cycle which we can understand, including the ejection, the rapid inflow and the atrial systole. So as we've already understood, the 2D picture does give us an understanding which is qualitative, but we need the M mode and the Doppler for further understanding of the rhythm. M mode, as Dr. Shanti suggested, we need to take the atrial appendage and the ventricular wall and plot it off. The limitation of M mode is the measurement of the interval is not as reliable. Dopplers can be taken with LV inflow outflow, aorta SVC, pulmonary vein, pulmonary artery, or whatever combination we understand of the atrial and the ventricular activity. And the measurement of the interval is more reliable with Dopplers. Also, we can take the color M mode where we put the color Doppler and then put the M mode tracing. Now coming to the ejection, we can take any of the semiluna valves. The rapid inflow is typically seen in the E of the AV valve and the atrial systole in the A of the AV valve, or even ductus venosus or pulmonary vein. Now the cornerstone for diagnosis of any arrhythmia, whether it's going to be tachy or brady, is going to be the PR interval, which is going to be the onset of the A to the onset of the V. How do we measure it? We can take the LV inflow outflow, and how we take it is the beginning of the A to the beginning of the V. Or we can take the aorta SVC simultaneous Doppler and the beginning of the A to the beginning of the V. Now with this understanding, let us just understand the irregular rhythm. Now, whenever you see the rhythm which is irregular, it can be because of a premature ventricular contraction or an atrial contraction or any type of a second degree heart block. Overall, a ventricular contraction premature is very, very rare compared to a premature atrial contraction, and sometimes it's difficult to diagnose in fetal life and differentiate them. The premature ventricular ectopics typically will have an absent A wave, and if you Doppler the SVC, you will have a prominent A wave. Try to rule out cardiac tumors and myocarditis whenever you suspect a ventricular ectopic. In contrast to that, when you have a premature atrial ectopic, what you lose is the E wave. And that too, not only in the beat, which is premature, but if it's a blocked PAC, the next beat is also going to have a missed A part. That means the passive ventricular filling is not happening for 2 beats consecutively if it's a blocked premature atrial beat. In contrast to that, if it's a conducted beat, you do not have the E wave for the premature beat followed by a ventricular beat, and then the subsequent beat you have an increasing gap or a pause between the E and the A wave. So let's just see this. So when you see the 2D picture running, you will realize that there is something which is intermittently irregular. And then when you take the V wave, you will realize that the rhythm is irregular. And then you start understanding what is happening. On M mode, you can see that the atrial contraction is not followed by a ventricular contraction. There is a longer pause followed by a atrial beat. And when you Doppler the AV valve, this is what you see. So you see an E and A followed by a V, E and A followed by a V, and then you have the A wave. So that is the premature atrial contraction, which is not conducted. And then you have a premature atrial contraction followed by a V. And very interestingly, after that, you have this EA pause. So likely you have two atrial ectopics, one of which is not conducted, one of which is conducted. So this is atrial ectopic non-conducted. And let's see this, you have an M mode, and then you have the Doppler, where you see the atrial ectopic, which is conducted, and then you have an E and A, which is having a pause. So this is the atrial ectopic, which is conducted. Now, whether it's conducted or not conducted may not make a difference, but what is going to make a difference is how frequently do we have anything like this? Now, if you see here, on 2D, you will realize that it's sort of regularly irregular. When you do the aortic Doppler, you will see that the volumes are alternatively different. This is the umbilical artery Doppler. And when you see here, you can see that you have EA and V, and then you have A and V, and then you have EA and V. That means you have alternate atrial beats, which are ectopics and conducted. So it is atrial bigeminy, which is conducted. Remember, when you have a bigeminy, trigeminy, couplets, triplets, there is a possibility higher to have SVT, though overall it's just in 0.5% of cases. No treatment indicated. Once in 4 weeks, fetal echo with intermittent OBGY observation is sufficient. Coming to tachycardia, a little change in the heart rate in terms of tachybrady is physiological. So remember the definition that the heart rate between 160 and 180 or more than 180 is abnormal. Tachy is more common than brady. Structural heart diseases like Epstein's or rhabdomyomas can happen, including myocarditis with tachy. There is a definition which is defining it as intermittent or persistent tachy. Intermittent means it's happening less than 50% of the time duration of your examination. Now, we all know this is exactly similar understanding as what we see postnatally. If it's an ectopic atrial tachycardia, what you can see is the PR interval is short or the RP interval is long, and we have a slow onset with a slow offset. If it's a flutter, you're going to have an atrial rate much higher than ventricular and sometimes changing ventricular rates. If you're going to have a reentrant tachycardia, you have an abrupt onset and offset with a short RP or a long PR tachycardia. And AVRT is the most commonest fetal tachycardia. The typical feature is it's extremely regular with fixed rates. Ventricular tachycardias and nodal tachycardias are much less common. Just to summarize, if your atrial and ventricular rate is equal, it can be an AVRT or an ectopic atrial tachycardia or a sinus tachycardia, but AVRT is much more common even compared to a sinus tachy in fetus. Atrial flutter commonly happens in third trimester. These are just few clues which can help you to tilt towards a particular diagnosis. The cornerstone is going to be the PR interval, because if it's a short RP, it's going to be an AVRT. And if it's a long RP, it's most commonly going to be an ectopic atrial or a sinus tachy. If you have an AV block, think of an atrial flutter or an ectopic atrial. You can't have an AVRT or a necessary pathway with a AV or a VA block. Now, a sinus tachy, very importantly, does have heart rate variability. I think the net connection is a little slow. So it does have a heart rate variability, which typically favors sinus tachy. The rates are usually between 180 and 200, and try to rule out maternal causes like thyrotoxicosis, anemia, sepsis, etc. Coming down to the two most common difficult differentials is AVRT and ectopic atrial. And remember that ectopic atrial tends to have the heart rate a little on a lesser side, usually in the tune of 200s, whereas AVRT has a rate on the higher side most of the times, 220, 230, etc. If it's a short PR or a long RP tachycardia, think of an ectopic atrial tachycardia. And if it's a long PR or a short RP tachycardia, think of an AVRT. I'll wait.
Talk is very valuable.
Time to. Okay, so the sinus tachy we have done. The differences between reentrant and ectopic atrial we did. And sometimes you may end up with tachy and brady in the same fetus. So what do we do? The classical thing you will think is in terms of either atrial flutter or long QT or mother with antibodies positive. So just to, when you have a glance on 2D, you know that this is tachy with heartbeats of 210 on M mode and Doppler. And then let's see what is this. So you have this M mode where the atrial beats and the ventricular beats are seen with every atrial beat followed by ventricular. And you can see that the distance between the A and the V is quite short. This is the aorta SVC Doppler where we have measured the PR interval, and you can see that the PR interval is shorter. How do we define it? Most of the times, if it's less than 100 milliseconds or if it's less than 50% of the RR cycle, then it's considered to be a short PR, long RP tachycardia. So this favors an ectopic atrial tachycardia or a PGRT rarely. Here you can see that every A is followed by V, but see the difference compared to the previous slide. So you have a little longer distance between A and V, and your PR interval documented in inflow, outflow Doppler, and aorta SVC. However, sometimes you could be fortunate to see this where you see a sudden offset, sudden onset. And then you know that this favors AVRT. So here the diagnosis is long PR or a short RP tachycardia. You have charts available which will sort it out based on the heart rate and the intervals. The treatment is based on multiple factors. More than the mechanism of tachycardia, it depends whether you have an intermittent or a persistent tachy. Most of us will agree that intermittent tachycardias would not need aggressive maternal treatment, but just a follow-up. Gestational age, if you're near term, you would prefer delivery rather than maternal treatment. Earlier gestation is a bad prognosticating factor. Presence of CHD is again a bad prognosticating factor, and fetal well-being in terms of cardiovascular profile score and hydrops. The goal is to actually have a term delivery of a non-hydropic baby. You want to avoid or prevent hydrops and convert it into sinus, if not, at least reduce the heart rate. Most of the situations we have transplacental treatment. The response to treatment is much better if you have no hydrops. Once you are done with that, long-term prognosis is beautiful for babies. Most of them are off medications in the first 1 year of life. 3 common medications used as the first line drug. Most of us would try to use digoxin because it's well established role and well experienced. It can be IV or oral as a loading, followed by oral. A little mention here that the DIG levels are usually expected to be a little higher to get effective fetal benefit, and the levels should be measured 6 to 8 hours after the dose given. In case of hydrops, digoxin is not a good line. Flecainide is better in hydrops. It is used either as a single line initially or in conjunction with digoxin. It does have a maternal and fetal pro-arrhythmic effect, including sotalol also. Sotalol is a drug of choice for atrial flutter, sometimes used as a first-line drug. Remember, the mother, initially before starting any maternal treatment, mother needs to undergo investigations in terms of renal function, electrolytes, calcium, etc. Maternal ECG needs to be repeated every time a new drug is added or the dose of the medication is increased. For junctional and ventricular ectopic, we have other antiarrhythmics, including amiodarone, and also when the mother is SSA positive, the use of dexamethasone and IVIG is described. So finally, for any tachy, if the rate is more than 180, if you have 1:1 relationship, think in terms of sinus tachy. With shorter PR, think of ectopic atrial, and longer PR, think of AVRT. If it's not 1:1 relationship and atrial rate is more, think of atrial flutter. And if ventricular rate is more, think of ventricular tachycardia. Now, coming to the bradycardia part, again, we have physiological variability for a transient time. Here, very important understanding is that there is reduction in the heart rate with increasing gestation. So any heart rate in general less than 110 for 10 minutes is fetal brady, but between 100 and 110 is also not normal. And always try to follow, when you are in the borderline zone, follow the heart rate for that gestational age to decide where we fall. Now, three common understandings when you have brady. It can be either a sinus brady, or it can be an ectopic atrial which is blocked, or we can have heart blocks. Sinus brady is actually not that uncommon. Most of the times you have heart rate reactivity. Many babies have prolonged QTC after birth. So whenever you have sinus brady, nothing active needs to be done, but make sure that you have checked your IVC, as Dr. Shanti said. You do not have IVC interruption or any evidence of atrial isomerism. Check out maternal antibodies and rule any maternal medications which are on. Once that is done, most of the times nothing actively needs to be done. Long QT can present as brady initially, or blocks, or even torsades, so ventricular tachycardia. So multiple presentations of long QT. Avoid QTC prolonging drugs for the mother and ensure normal magnesium and potassium for the mother. The baby's ECG is a must at birth whenever you have sinus brady. Now, atrial ectopics we have discussed. The only differential which we need to understand is between blocked atrial bigeminy and 2:1 AV block, where 2:1 AV block will have regular AA interval. And AV blocks, we know that it can be with congenital heart disease, with maternal antibodies, or in isolation. And with congenital heart disease, AVSD and corrected transfusions need to be ruled out. Prognosis is poor. In contrast to that maternal antibodies, the prognosis is much better. There is a lot of information now in college. Remember, the fetal CHB is possibility high between 8 and 28 weeks when the mother, though rare case, session. Now here we can see that the heart rate is on the list. 65. This is entry top 45 to 50. Multiple atrial beats, no coordination. If the mother is antibody positive, remember, if your ventricular rate is less than 55, atrial rate less than 20, or presence of tachycardia, child. Unfortunately, a lot of information about weekly following up or checking for long PR and measuring the. However, remember that a normal PR can develop CHB within days, and a prolonged PR whenever. It's not considered to be a perfect tool, but still it's practice only. Steroids, 6 is on 4 milligram is recommended second degree AV. In terms of complete heart block, whenever it is taken into consideration, most of the times ventricular dysfunction or further hydrops, but do not revert back to either to a time. Immunoglobulins, steroids, inflammation is and beta stimulant sector and help increasing heart rate to some extent. However, it does not change the mortality in the baby. So just to summarize, if you have a regular VV interval, it's going to be sinus brady. And if you have an irregular VV interval with more atrial rate than ventricular rate, it can be blocked atrial ectopics or an AV block. Do not forget the cardiac functional assessment. Cardiovascular profile score of 10 is usually normal, and hence it's important to Doppler the ductus venosus, umbilical artery, umbilical vein, cardiac functional assessment, which we already went through. So just to summarize, what is more common? Ectopics are more common than tachy, than brady. Sometimes you may not need aggressive intervention like in ectopics, intermittent SVTs, SVT near term, complete heart block. Most of the times there's no choice for an antiarrhythmic, but protocols do exist. Do not forget the mother when you try to diagnose an aberration and also while treating. Thank you so much.